Next on Time for Living, managed health care. The future of health care is here and growing, but is it your best option? How do you know? Our experts, your questions next.
In our second ever salute, you'll meet a former teacher turned entrepreneur after age 60.
And we'll be traveling around the picturesque historic sites of the country of Israel. All coming up next on Time for Living. I'm Janet Jagalian.
And I'm Rex Traylor. Welcome to this edition of Time for Living, where we address the issues of the day that impact the lives of so many older Americans.
And this week, we take a close look at the issue of managed care, the broad approach to health care that aims to lower the costs by arranging care at predetermined or discounted rates. Now, this includes the difficult decision of which doctor and which hospitals a person could use and how those treatments and referrals are handled.
Well, coming up, Time for Living's Barbara Brilliant will host a special roundtable discussion. But first, she has a look at this close-up at the issue that is producing a mix of hope and fear for older Americans.
Hello, Mr. Olmsted. How are you doing?
Nice to see you again.
Nice to see you. Been feeling well?
What was once a phenomena a decade ago is now the norm for 4 million Medicare beneficiaries. Managed care has become the great promise to reduce skyrocketing health care costs. But debate in the medical community is still raging over what the human cost will be in efforts to cut costs through managed care. Experts on 3 sides of the issue addressed the question of managed care at a recent seminar at Harvard University in Cambridge, Massachusetts. Dr. John Delph of Pilgrim Healthcare, a not-for-profit HMO, says the medical industry is getting a handle on costs thanks to managed care.
HMOs, like mine and like many of them, and in fact like the for-profit HMOs, have better records in preventive health care than the fee-for-service sector. We have major investment in facilitating access, in screening, in promoting early intervention strategies. We provide aggressive, high-quality care typically earlier, and there are quality studies which show that our outcomes are often better.
That enthusiasm for managed care is not shared by Dr. Steffi Woolheimer, Director of Physicians for National Health, a group advocating a single-payer program run by the government.
In fact, the for-profit HMOs do have a track record, and their track record is, 1, that they shun frail elders, they shun sick people, and 2, that when they have frail people within those systems, they do rather poorly.
Dr. Woolheimer says the number is held up for review by managed care operations forgot to mention what she says is cherry-picking of patients, picking only the healthiest of older Americans to keep the cost of their program in line. That claim is refuted by many in the medical community who say the monitoring by federal authorities at HCFA, the Healthcare Financing Administration, which runs Medicare, guards against that. Medicare managed care plans are now available in all but 9 states. These plans often provide more comprehensive coverage than traditional Medicare. And while subscribers continue to pay the usual Medicare Part B premium, costs are generally lower than under traditional Medicare.
Gary, how are you doing?
Oh, fine.
Supporters of managed care say the program will guarantee that older Americans receive better care over the long term with more safeguards and more choices. Dr. Arnold Roman, editor emeritus of the New England Journal of Medicine, points out that the long-term results will be determined by expectations that are set within the health community.
There's a myth about the enormous range of choices that people have or have had in the fee-for-service system. Actually, the way it works out is that most people don't sit down with a book which lists all the qualifications and names of all the doctors they might go to. They go to some doctor that a friend or their relative or their own doctor tells them to go to. And they're very diffident about changing doctors because they don't want to offend the doctor and they want to get good care. So the range of choice that you have is kind of theoretical. And also it depends on how smart you are in using the system, as is true of so many other things in American life. If you're well-to-do and educated and you know your way around the system, you can move very easily from one doctor to the other. If you're not too well educated and you're poor, it's very hard. You have no choice.
While some doctors are opting out of managed care and some critics say that bottom line dictates the quality of care, others are saying that managed care, or HMOs, will give older Americans the benefits they need later in life. Whatever the answer, Harvard University's Dr. John Delf says there is one constant in the debate.
With relation to a single payer, national health care, etc., that debate is unfortunately over. Capitated coverage is here and we need to deal with it. In fact, the Canadian system is hemorrhaging and falling apart. I don't like that, but it's a reality.
40 million Americans, many of them over 50, remain without health care. They'll be watching in this next year as the government and managed care providers fine-tune the system to provide better care for fewer dollars. Barbara Brilliant, Time for Living.
When we come back, we'd like to get your comments and concerns about managed health care. You can call Time for Living at 617-244-3344.
And Barbara Brilliant will be joined by two experts on the issue of managed care. Their comments and your questions when Time for Living continues.
Three, 4, 5, 6, 7, 8, 9, 10. Count, please.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Welcome back to Time for Living. I'm Barbara Brilliant. Our issue today is managed care, and we asked you to call in with your questions to 617-244-3344. Our special guests today are Dr. Alan Abrams. He's the president of the National Institute of Community Care and a member of the Harvard Medical School, and Dr. Benjamin F. Gill, assistant clinical professor of psychiatry of Harvard Medical School. He's here today as a member of the Physicians for a National Health Program. Welcome, gentlemen. This is a very complex, complicated subject. We saw the piece prior to this segment, and it brought up a lot of very interesting questions. Right now, we have 4 million Medicare recipients, beneficiaries on Medicare, on managed care. What is managed care? Is it HMOs? Is it Medicare HMOs? What is it?
Well, managed care is a general term that, that means that people are looking very carefully at the utilization of medical services. And there are a variety of ways that organizations can go about looking at the utilization of services and trying to impact the utilization rates of all kinds of healthcare services, from laboratory tests to pharmaceuticals to inpatient stays to operations, et cetera.
All right, so we're trying to be more efficient. I know they have that in the managed care. It's more a wellness model than an illness model, which sounds good. But Dr. Gill, you feel that the managed care HMOs are not the way to go for older people. Is that correct?
That's absolutely correct. Excuse me. They're very attractive because they don't cost as much as a regular Medicare fee-for-service program does. They can see physicians for $5 a visit. They can get drugs for $3 a visit.
Well, what's wrong with that, Dr. Gill?
There's not a thing wrong with the cost, because most of the elderly people who are eligible for Medicare are very poor. Their incomes, 80% of them, are less than $25,000 a year, so that anything that can reduce their medical expenses is a very attractive proposition. In addition, the Medicare HMOs promise to give you more than the fee-for-service Medicare government-run program does.
Mm-hmm. Is this true?
That is true in some respects. In the respect of some preventive care, in respect of some drug coverage, the HMO Medicares do, in fact, give you more. However, my concern is, particularly with the for-profit HMOs, that their interest is in the bottom line. Their interest is less in providing health care. In fact, their legal responsibility is to their stockholders and not to the patients.
Dr. Abrams, do you agree that the HMOs will compromise care for older people?
Well, I think that it remains to be seen whether it will or it won't, but I think there are a number of things that are concerning that we meaning all of us in the healthcare delivery system, need to be careful about. I mean, the older adults, especially the sicker older adults, are one of those subpopulations that are not really able to advocate for themselves, and there are a lot of older adult organizations that try to advocate for them, but we need to be careful as we refine the healthcare system over the next 5 to 10 years that we don't leave important things out just for the sake of cost, that we find a way to provide high quality care, comprehensive care, and do it at a reasonable price.
Right, and we all agree, and you know, whether we want managed care, we don't want managed care, it's really not a debate. We're going to have it, it's going to happen, and we need it. Everybody has to be covered. I'm interested in a piece that Dr. Delph said. He said with managed care, they are finding better outcomes for older people, and I found that interesting.
That's not true. That's not true. A study was recently published in the Journal of the American Medical Association, which showed that people in Medicare HMOs had poorer results over a 4-year term than in people people who had fee-for-service in the standard Medicare program.
And I think also, you know, I think that Dr. Delph may have been referring to some report card data on some of the preventive measures. And certainly in a managed care organization has the systems in place to make sure that nobody goes without their mammogram or their flu shot or, you know, things of that sort, which are incredibly important things for people, for the quality of their life and for their health. But I think that we don't really know yet whether the managed care organizations can do as good a job as the fee-for-service model in taking care of frail elderly people with lots of illnesses.
You know, Dr. Abrams, and I have to agree with you because this is a new system and it's going to take a while. But if you're sitting out there and you're 85 years old or 90 years old, you need to have that resolved today. We can't wait for it to kind of work itself out and figure out what's going to happen.
Well, there are a few things that I think are advantageous about a managed care Medicare organization. And I think one thing is that the primary care physicians in that system have a tremendous amount of responsibility for each individual person that they take care of. And I, as a physician in practice, have myself heard patients frustrated about some of the availability of some of their physicians or the physician's office to respond to them. There's incentives in place in this managed care system for people to get prompt, active responses from their primary care providers. And I think that that is something that's good about it.
Let me ask you about incentives. What about incentives for doctors? And we all hear about incentives for doctors that they have to comply within a bottom line, or else they might be relieved of their duties for certain HMOs, that they have to be careful about not sending people to too many specialists, that they have to limit hospital stays, and in that regard, what happens to the hospital beds if they're empty? I mean, it's a complicated subject.
Well, Barbara, many HMOs have what they call risk contracts. And risk contracts mean that the doctor who provides less care to their patients get more money. So there's an immediate conflict between what the doctors are paid and the care that they give their patients.
Are we talking about accredited HMOs now? When you're talking about,
we're talking about an HMO like U.S. Healthcare, for example. They have published themselves a schedule showing that one doctor, who they called Dr. Frugal, could make $260,000 if he limited the number of consultations with specialists, if he limited the number of hospitalizations, if he limited the number of emergency room care. Whereas Dr. Frugal would end up with nothing if he exceeded certain limits in those respects. So there's a direct conflict between the amount of money that the doctor makes in a risk contract and the amount of care he gives. In other words, it is a stimulus for them to withhold care.
I think it's important, though, to explain to people that the relationship between the managed care organization and the physician and the way that money moves in the system is a very important thing for them to understand when they're signing up for these managed Medicare programs. Because while there are organizations that may provide financial incentives that will alter the physician-patient relationship and actually create some ethical dilemmas for a physician who is on the one hand a patient advocate by tradition and now under this new managed care system has a certain allegiance to the organization. On the other hand, there are HMOs, managed care organizations, which pay their physicians on a completely different basis and hold them less specifically responsible for the bottom line costs on each individual client. So those organizations, some of them in the greater Boston area and available in Massachusetts, do a better job.
Alan, you bring up a good point. Should this be one of the questions? If a person is interested in joining an HMO, should they ask, how do you pay your doctors? Would that be a good point?
I think it's critical for people to understand under what kinds of conditions the physicians are operating. And I don't mean in surgery. I mean under what financial incentives are the physicians operating, and I think that they have a right to know that.
And the other thing, I'm sorry,
many other questions people should ask, I think, before they join one of these Medicare HMOs, for example, is can the doctor be fired without cause? Will the doctor be there for them? Will their deductibles and co-pays go up? Questions like that, I think, are very important for people to be aware of in terms of before they enroll in an HMO.
Let me ask you to respond to something. Dr. Martin Solomon of Brookline has written editorials in the Globe, I'm not talking out of school, New York Times, and he says that, and I'm paraphrasing, that managed care systems are strip mining health care. It's bad for the patients, it's bad for medicine, it's bad for research, it's bad for doctors, and Dr. Solomon's solution is a single payer plan to ensure that everybody has a basic kind of health care, and then beyond that, those who wish could pay some insurance fees and go to their own private doctors.
That's exactly correct. And I would like to take issue with Dr. Delfs and what he said about single-payer health care as if it were a dead issue. It is absolutely not a dead issue. I am very active in MassCare, which is Massachusetts' campaign for single-payer health care, as well as in Physicians for National Health Program. We have recently filed a bill, MassCare has recently filed a bill, a single-payer bill in the legislature. We filed one 2 years ago. This year we have more sponsors in the House, more sponsors in the Senate than we had before. We have also gotten the Massachusetts legislature to do a study of single payer and what the impact on this state would be, don't forget we have 600,000 or more people uninsured in this state, almost 10 or 12% of the population. That is disgraceful in these days. We are the only...
Yes, we're going to discuss more about single payer, but Rita's been waiting on the phone. Rita from Needham, your call, please.
Yes, good afternoon, Barbara. I was wondering if you and your experts could address the subject of specialty care, and if in managed care plans it would grant individuals access to specialists, because I have heard personally many horror stories where individuals have gone to their managed care plan, for injuries, orthopedic, and they have not been referred to specialists, and they have not done well at all.
Alan?
I think that my understanding of the way that most of the organizations have been developed is that they've been developed with the primary care provider as the gatekeeper. And that means that the primary care team, whether it be a primary care physician with or without a nurse practitioner or physician's assistant, see and hear about their patients first, and then they make decisions about what kinds of specialists are required. Now, that's not a lot different than the fee-for-service model, where you would generally call your internist or primary care provider. But in the fee-for-service model, you can decide, if you have a twisted ankle, to go straight to the most highly recommended specialist on ankles in the Boston area if you feel like it and if they have time to see you. So there is a little bit of a difference there. Also, most of the managed care organizations have a network of physicians that are their specialists, so that when it does come to finally being referred to specialty care, not only is it important for you to be happy with the primary care providers on the medical care organizations list, but you also better take a look at some of the specialists, surgeons, mental health providers, etc., as well as hospitals, long-term care facilities that you will be referred to if you should need them. And I hope that answers your question.
Thank you very much, Dr. Abrams, and thank you very much from Needham, Rita from Needham. We're going to go to a break now. We solicit your calls at 617-244-3344. We'll be right back. Is the prompter person alive? Okay. I think Welcome back. We're talking about managed care. We're talking about elderly, and we want to get your calls. Our number is 244-3344. We have a call. Caller, please.
Oh, hello?
Yes, hello.
Yes, this is Norma from Reading, and I thank you for taking my call. I'm very interested in this managed care situation because when I retired, I had an HMO when I was working, and it did serve me well. I knew that I couldn't really afford a fee-for-service and one of those 80-20 things, you know, if you're going to surgery. So I did go with an HMO when I retired. Over the years, I found that it isn't quite what it used to be, and I'm really, really annoyed. I'm worried. I'm for a single-payer health plan.
Single-payer health plan.
Yes.
Thank you. Dr. Gill, just explain what single-payer is.
A single-payer health plan is where one agency collects the money and pays out the money for health purposes. It also regulates fees, regulates equipment prices, regulates drugs, so there's some cost containment, and it is run on a non-profit basis. So the money we now spend for our health care in this state, $30 billion, could cover everybody.
But Dr. Gill and caller, please bear with me as well. I'm originally from Canada, and they have a single-payer system. They use 7% of the gross national product for healthcare, not anywhere enough. And the dean of the McGill Medical School said to me, Canada's not a place to get sick in. That's a single-payer system.
Well, I'd have to point out, I think, that a single-payer system is not a free ride. It's not a free lunch. It costs money. And the problem with the Canadian system at the present time is that the provincial legislators are not willing to provide enough money to run the system the way it should be run. And that is a really serious
What percent of the GNP do you think it would take to have a proper medical care for all of our citizenry?
Well, currently we're spending close to 15% of our GNP on medical care. I think we can do it for 10%.
Okay, thank you, doctor. We have another call. Go ahead, please.
All right, can I continue?
Oh, you're still
all right.
there.
I thought that all right, this is still Norma. I think we've gotten a lot of misinformation as far as a national health plan is concerned. I don't know how we can get that much better care with the HMOs when they are spending money on advertising. How many times do I see a commercial on TV, on the radio, in newspapers, magazines? I mean, this and TV advertising isn't cheap. And I hate being put in the place of being considered as a commodity.
Alan,
I think it's demeaning to me. I think it's demeaning to physicians.
Thank you very much. Dr. Abrams.
Well, I think that the managed care organizations are doing what they have to do to attract people to them so that they can actually meet their goals. Whenever you're in a capitated system, that is when you get paid a certain amount of money per member per month in order to run your healthcare system, in order to spread out the risk, you have to have as many people in the program as possible. And that's the way, that's the best way financially that even a national health program would work. Which is...
Alan, I beg your pardon, that's not true. They don't have to advertise. Everybody would be a part of it.
I understand that. I understand that. I'm not saying a national... What I meant was that a national health program also would need to spread out the risk in order to minimize the cost and allocate the resources as best as they could. Now, I agree that we are spending a significant percent of our healthcare dollars on the administrative, which includes marketing costs of the development of successful health maintenance organizations and managed care organizations. We could save some money there. I do want to say, though, that not all managed care organizations are evil. That there are many good ones, and that people do receive good care even when they're sick. I know of an organization that's affiliated with the Winchester Hospital in Winchester, where they have a special risk stratification program and wellness program for seniors in that community, and they have some of the best outcomes, although it's not from a research point of view statistically significant yet. They have some of the best outcomes in terms of the quality of people's lives, the health of their older population, and generally the satisfaction of the people who are part of it.
Well, thanks, Alan. That's encouraging. We do have another call. Go ahead, please.
Hello.
Hello.
Yes, I'd like to ask them, what responsibility does the patient have towards the program? I find people overweight. You see them in the doctor's office. They can hardly move. They're diabetics. They're, they have different disease. They don't go to see a doctor often enough. Now all of a sudden they have all these things wrong. Somewhere along the line that should have to be measured, and the patient should have to be responsible for his own health care, not somebody else.
I agree with you, caller, and I do say if you're part of a managed care program or any program, even a single-payer plan or a private doctor, you have to take responsibility for your own health. There's no question about it.
Yes, and I think some of the HMOs emphasize lifestyle and correcting lifestyles that may lead to ill health. I would like to add something to what Alan said about the administrative costs in HMOs. They run 25 to 30% of the healthcare dollar. In other words, 25 or 30 cents of every dollar you pay in a premium goes to administration, goes to advertising, goes to profits, goes to paper pushing, goes to mega $1 million salaries, and that money...
But doctor, if we're talking about a single-payer plan, I'm from Canada.
Yeah.
I don't think that's a panacea. In the piece that we saw at the beginning of the program, it said that it isn't really that wonderful. I mean, I would not like to see the Canadian system here for our citizens.
Well, let me tell you something, Barbara. When polls are taken about the Canadian system, the people in Canada are more satisfied with their health care system than any other country in this world, including the United States, which is at the bottom in terms of overall satisfaction. The people of Canada are more satisfied with their system than any other healthcare system in the world. So that to say that it is not an effective system or a popular system, even among the doctors, I think is a mistake.
Well, I'm not sure about that because I know a lot of physicians, but I just want to take this call and we'll get back to that.
Could I answer that
certainly.
last caller's? His question really was about how much responsibility does an individual person have for their own health? And I just wanted to put this out there that, I really think that when it comes to health care, that we all need to be pushed to do the best that we can. But the bottom line is really that when you get sick, you don't want to be blamed for it. And if you're overweight, or if you're somebody who's addicted to tobacco, that is a smoker, if you are somebody who has diabetes, there are some lifestyle things that you could do, but it's not completely your fault. And we as a country have to get out of this mindset that everybody is responsible for themselves until they get into trouble. Either we're going to lick this healthcare financing problem together, or each man for himself. And I think that we do better as a community and better as a country if we try to work together. And we're willing to say, some of my premium, if I keep myself healthy, can go to you if you're not feeling so well.
Well, that goes without saying. There's no such thing as a free lunch in terms of health care or anything else. But we have one quick caller, please. Caller, are you there?
Hello.
Hello.
How are you today?
Fine, thank you.
Okay. My name's Richie. I'm from South Boston.
Hello, Richie.
Okay. Listen, I'm disabled. Okay. I had two, one open heart surgery and 2 lung operations, chemotherapy, radiation, all. And I'm under psychiatric counseling. Now, I went to, I'm at a hospital here in Boston, okay, New England Medical. And I went to a private place. I called a private place, and they denied me. They said
they denied you what?
To stay there for psychiatric counseling.
Mm-hmm. That's a very interesting question. Let's ask about this managed care in terms of mental health.
Well, I think that to date, I think that the managed care organizations have not really provided enough resources for people, especially older adults, to get the mental health services that they really need. There was a cartoon, if I can describe it, of a psychiatrist in his office with a patient standing there next to him, and the psychiatrist had apparently just slapped the patient across the face, and the caption read, "Snap out of it." And that was supposed to depict in caricature the kind of mental health benefits that the managed care organizations have been providing. And while it is humorous, there is a side to it that is not so humorous. In the older adult population, there is 20 to 30% of people with medical illnesses have concurrent psychiatric, psychological problems that ride with their medical illnesses and impact on the quality of their life. And I think if we're going to develop a managed care system for older adults that's going to work, it has to address the psychological needs as well as the physical health needs of the older population.
Very well taken. Dr. Gill, do you have anything as a wrap-up for us?
Well, I think that our healthcare system in general is a mess. And I think that the HMOs have been an attempt to straighten out some of the problems, particularly with respect to cost. The other alternative is a single-payer healthcare system, which would provide comprehensive coverage to everybody, which the HMOs do not. A single-payer system would also provide for research and for teaching, which the HMOs do not. And so it would be a much better system, but that's not to say it comes cheap. However, the money is not going to be spent on administration. Medicare runs for 3% administration. The HMOs run between 25 and 30% to cover all their administrative costs. So that the money, instead of being spent on administration and advertising and this sort of thing, will be spent on people's health. And that's where I think we need to go.
Thank you very much, gentlemen. Thank you very much, Dr. Gill, and thank you very, very much, Dr. Abrams. This is a complex subject. It's a subject we all have to do a lot of research into and make sure we're getting the very, very best health care. The Health Insurance and Counseling Assistance Program offers free information and assistance on Medicare, Medicaid, Medigap, long-term care, and other health insurance issues. You can call them at the number listed in your state where you live. In Connecticut, call 1-800-994-9422. In Maine, call 800-750-5353. In Massachusetts, call 800-882-2003. In New Hampshire, call 800-852-3388. In New York, call 800-334-4114. In Rhode Island, call 800-322-2880. And in Vermont, it's a direct dial number. That's 1-802-828-3302. When we come back, second effort salute. Don't go away.
Well, Janet, it's time for our second effort salute.
Yes.
And this week we take a look at a remarkable woman who waited almost 3 decades to make a career change.
You know, on the brink of turning 50, Carolyn Burns decided that it was time to call it a career as a teacher and embark on a new and promising challenge. And with our second effort salute, here's Rod Fritz.
I thought, I'm not ready to retire. I'd go out of my mind if I had nothing to do.
Carolyn Burns has plenty to do, and she does it quite well. 17 years ago, at the age of 48, the Scituate, Massachusetts high school chemistry teacher decided she needed a change, and she looked outside the classroom.
I realized that there was a great big world out there, and that I had been missing it for the last 25 years.
The grandmother of 7 took some night courses at Harvard Extension, and at the age of 49, took a job with a Boston engineering firm.
Actually, I found the work at the engineering firm, though I had an awful lot to learn, easier because I never had to correct papers on weekends and at night. It was great. When I came home.
Carolyn worked at the firm for 12 years, and then came another major change.
When they wanted me to go to Amarillo, Texas for the summer, and it's very hot there, and I live where I do because I like the summertime. I said, I don't think so. And they said, well, I don't think we see too much for you in the future. I said, thank you, goodbye, and started my own engineering firm, my own consulting firm in occupational health and safety and environmental compliance.
Carolyn's firm, CCB Enterprises, is doing just fine. She worked with the Army Corps of Engineers on the Watertown Arsenal cleanup and hopes to land an on-site consultant's job on the Central Artery Third Harbor Tunnel project. To others thinking of career changes, Carolyn has this advice.
I say be adaptable, keep on learning. The day you stop learning is the day you're dead, as far as I'm concerned. Find a niche and work on it.
A wise thought from a wise woman. I'm Rod Fritz. Time for living.
And now coming up, let's go traveling around. This time we take you to the Middle East.
The country of Israel, to be exact, where pilgrims from all religions come to this very special place. Traveling Around is next on Time for Living.
This week, our Traveling Around segment takes us across the Atlantic to the Middle East for a close look at Israel.
For over 4 decades, this nation has been a mecca for pilgrims worldwide. It's a rich blend of history, religion, and economic growth. And that's become a favorite tourist spot to visitors both far and near. We begin our journey to Israel with a visit to Tel Aviv's Carmel Market. 80 different ethnic groups call Israel home. In Haifa, the old Arab section of Tel Aviv, Jewelry makers ply their trade. As a whole, Tel Aviv is a modern place, yet those with a pioneering spirit can escape the big city into the heart of the Negev. Some of this desert has been transformed into productive farmland, but much remains as it has been for thousands of years. Today they still welcome you to their tents for coffee. The beans ground in a rhythmic pattern unique to each family. From there, a 2-hour camel ride brings you to the hilltop site of Olda. Over the centuries, Roman and Byzantine settlements were built on top of this old city. You have to have a sense of adventure to spend 3 hot, dusty, bumpy hours rolling through this arid landscape. You'll miss a lot unless you speak Hebrew, so make sure you choose a jeep journey where English is spoken. From the Negev, it's on to Jerusalem, where you'll find the Western Wall. Here is where Jews come to celebrate their faith. Just behind the wall, the Dome of the Rock, where Muslims believe the Prophet Muhammad ascended to the heavens. 2 religions, 2 profoundly different sites. Over many centuries, Jerusalem's blessing and its curse has been that it is a holy place for Christian, Muslim, and Jew. You'll find religious sites here for all 3 faiths. Here you can walk on the same path that Jesus trod on the way to the crucifixion. The Church of the Holy Sepulchre, where Christians believe the cross of Jesus stood, and the tomb where he was buried and resurrected. For pilgrims, an intense religious experience. Now it's on to Israel's Dead Sea. People come here to float like corks, soak in the sun, and slap on the mud with its healing properties.
Is that walking down?
Not far is another place where we can revitalize the spirit rather than the skin.
The story here is a story of such heroism and resistance to tyranny that everyone who comes here, whether they're a Jew or a Christian, can relate to it.
King Herod built Masada 2,000 years ago, but he died before ever seeing his clifftop fortress. A few hundred Jewish zealots took over Masada, defying the mighty Roman Empire.
Here you've got a very good view of the Roman siege camp.
For 2 years, the defenders held off the Roman army. 900 men, women, and children beating back 10,000 soldiers. Finally, the Romans began knocking down the fortress walls at Masada. At that point, the defenders knew their cause was lost. Each man killed his own family, then each other, till all were gone.
They wanted to die in a way that would emphasize the way they had lived as people who resisted the tremendous power of the conqueror. They died taking their freedom with them. And this was the worst blow to the Romans.
You'll find security tight at many tourist sites in Israel. Struggles in the Middle East have affected the tourist trade, but Israelis are doing all they can to make their country safe for visitors. Israel, today's traveling around destination.
Welcome back to Time for Living. Rex, what are your hobbies? What do you like to do in your spare time?
Well, I like a lot of different things, but we're going to be right back, and I'll tell you all about it.
All right. And now welcome back to Time for Living. I asked Rex what he did in his spare time, and voila, it's here.
Well, first of all, I don't have much spare time, but I like to do wood turning. And
I'm impressed.
One of the projects I
think
did.
that's pretty extraordinary. And thank you so much for bringing it in. It's our pleasure right now to introduce two people who on different levels are making the most of their creative talents. First, meet Honey Doctoroff, who is the program director for Creative Horizons, a showcase for talent sponsored by the Tufts Health Plan for Seniors.
And beside me is Phil Bowman of Newton, Massachusetts. Phil took part in the Creative Horizons 1996 Crafts Fair, and I had the pleasure of being there. He brought along some of his work for us to see. So Phil, let's start off with you and tell us about some of these creative projects that you've been involved in.
Well, wood turning has turned into be an art form as well as being a utilitarian pieces such as this piece. And I enjoy using multi-woods and creating designs that have more color into it than a single wood.
Yeah, tell us a little bit about multi-wood. How do you select those?
Well, a lot of this is exotic wood. From this is bloodwood, it's called. And this is ebony. And I, on paper, draw designs, and then I have to figure out how I'm going to execute them. And but there's certainly a lot of interest in wood turning that uses just a single wood also. Right?
Well, you know, my little project there was a single wood.
Yes.
Look at this, Janet. Isn't this fascinating?
Most unusual.
Yeah.
I'm very impressed by all of this.
Thank you.
Now, where do you show this? Is this something that you're involved with, Honey?
Phil has outlets for showing his work. My involvement is with a program developed by Secure Horizons, which is Tufts Health Plan for Seniors. The program is called Creative Horizons. There's no controversy about the fact that the people who age most gracefully are those who keep themselves mentally and physically active, and this program is a celebration of the creative talents of seniors.
And how does someone get involved in it?
In your January-February issue of Horizons magazine, there will be an entry form for our second annual Creative Horizons program. Fill it out and send it in, and it will come right into my hands. If you're not a member of Creative Horizons, simply call my office. I hope there's the number on the screen for you, and I would be glad to send an entry form. People do not have to be as brilliantly skillful as Phil Bowman is in his presentation. This is a program which welcomes people of all levels of talent. There is no fee involved, and we hope that visual artists, literary artists, and performing artists will be part of Creative Horizons 97.
And I hope so too. I think it's just extraordinary. And we thank you both so much for being with us today.
Thanks for having us.
We'll be right back. Now, here's a piece of outstanding craftsmanship and something that we're really very, very proud of. Many of us were at the National Academy of Television Arts and Sciences and saw Rex Traylor receive this Silver Circle Award. And Rex, we were mighty proud of you.
Well, let me tell you, Janet, I was absolutely flabbergasted by the whole thing. It was a night to remember, and really thank them for that great honor. This is really terrific.
And your old sidekick gave you the presentation.
Oh, Sergeant Billy was right there. He did the introduction and did a very nice job on putting together the whole award ceremony.
There were 6 recipients of this, and Rex had a marvelous presentation, and it was just such a pleasure to be there with you and to see this honor bestowed on you.
Well, thank you, Janet. It was great having you be there.
Thank you.
Okay. And I'll tell you what.
What?
We have so many things coming up in Time for Living, and I just want to mention to all of the folks that this is your program.
That's right.
This is for you. And so what we want is plenty of input from you as to what you would like to see and hear about, things you'd like explained right here on Time for Living.
Keep your cards and letters coming, and we'll see you next week.
Okay, bye-bye.